Good day, friends, and a warm welcome to the very first episode of 4D Season 3.0. 4D means Detailed Discussion and Dialogue for Indian Diabetes. It's our show made by us for us, and here we understand the problems that we face, the challenges that we face when we handle diabetes in India. At the same time, we find solutions. We find that hidden resourcefulness, the hidden resilience that we all bring to the table when we manage diabetes in India. Warm welcome once again to the first episode, and for this we have three of the most dynamic people in the country. We have an endocrinologist, nephrologist and a cardiologist with us. So let's welcome them one by one. Dr. Sajal Kamath from Aditya Birla Hospital and Sahyadri in Pune. Warm welcome, madam.
Thank you, sir. Thank you for the warm welcome.
Thank you. Dr. Sajal, hormones. Now, you're an endocrinologist.
Yes,
What
sir.
does the word happy hormones mean to you? Can anybody be happy when they listen to a webinar with where an endocrinologist is there?
So basically, happy hormones, the hormones itself, the word to me is basically hormones is something that regulates all the systems in your body and keeping a balance. And that is what the word happy hormones means to me more than anything else.
And if we can take this to our patients, I'm sure they'll be much happier and more satisfied with us as well.
Definitely, sir. Especially they come to us saying, please, we have a hormonal imbalance, please balance kar do. So I think, that itself, keeping the hormones in balance or settling it for them is what makes them happy.
But happiness, they say, comes from the heart. So we welcome Dr. Tanmay Dilip. Dr. Tanmay is also from Pune. Dr. Tanmay, warm welcome.
Thank you, sir. Thank you.
Dr. Tanmay, happiness for you, what does that mean as a cardiologist?
So for me, happiness means there are two perspectives. One is, physical fitness. If it is there, then and disease-free life is what I feel is happiness in that way. Otherwise, once the patient starts having all the diseases behind them, and if they're not fit, they have some other symptoms. They are not never happy. And stress-free life is another thing where we should see for it, and that keeps us happy.
Physical and mental happiness, both are equal.
Happiness is.
For this balance, we need each and every organ system of the body to work properly. So we also welcome Dr. Ranjit Singh Dalvi. Dr. Ranjit is from Pune again, Sahyadri Hospital and Jahangir Hospital, a nephrologist. Warm welcome, sir.
Good evening, sir. Thank you very much.
And a question from the audience for you. What does happy nephrons mean, sir?
Happy nephrons is they are functioning optimally and they're able to contribute to the urine. And that's what makes body happy. So happy nephrons means happy body.
That is really nice. So now look at this perspective, such a selfless perspective. The nephrons are happy because they're able to keep the rest of the body happy. Look at it that way. And I think that is our work as doctors. We are happy when our patients are happy, when our country, when our community is happy. And I think we need to learn a lot from our nephrons, from the kidneys. We are working ceaselessly, tirelessly, just to keep the rest of the body happy and in a very humble manner. The heart, for that matter, the pituitary, the hypothalamus, they don't work for themselves. The heart keeps on pumping blood throughout the minute, throughout the hour, throughout the day, throughout life. Keep the rest of the organ systems normal. Of course, kabhi-kabhi gadbad ho jati hai. Sometimes you get in trouble, but still it keeps on working ceaselessly. And then the hormones are always there to balance things up and down. But Dr. Sajal, let's begin with this concept of metabolic syndrome. So we have happy hormones, we have happy heart and happy kidney. How does this unhappiness come in our body? What does metabolic syndrome mean to you?
So some metabolic syndrome basically is a combination of multiple factors. And as you know, as an endocrinologist, as diabetes was previously viewed as just glycemia, now this whole concept of metabolic syndrome, which not just includes the diabetes aspect, but includes the cardiovascular aspect, which includes hypertension, obesity, increased blood pressure, waist circumference. all of that comes as a metabolic syndrome. And now to add to that, we also have MASLD, the liver disease, which also forms a component of a metabolic syndrome. So basically, all of this is related to one common pathology, which is the insulin resistance and obesity. So the adipocytes, the refractory adipocytes leading to insulin resistance is the pathology or the pathophysiology behind this metabolic syndrome.
And Dr. Tanmay, we speak of the vasculometabolic syndrome, and now we have a new definition of clinical obesity, where they list 18 clinical conditions that will allow us to label someone as having clinical obesity. Out of those 18 conditions, 6 are directly from cardiology, directly related to cardiology, and then another 2 are metabolic, partly related to cardiology. So what are the aspects of metabolic syndrome from a vascular bed point of view and from a cardiac myocardial point of view? The sound of silence in that is in atypical angina and in heart failure. The term uses sounds of silence when you have atypical angina, but here we need the... And this is, one of the things that we see in metabolic syndrome. When we speak of metabolic syndrome from a cardiac point of view, we always think about heart attacks, about ASCVD. But there are so many other things like atrial fibrillation, maybe a bradyarrhythmia that is going on right now in our bandwidth. We are not able to hear properly. Other things. So, Dr. Tanmay, could you carry on then the other cardiac manifestations, the other vascular manifestations of metabolic syndrome? Dr. Kajal, could you carry on with the discussion, please? The cardiac manifestations of metabolic syndrome that you encounter in the OPD, and then where we need to refer to the cardiologist.
Yeah, so metabolic syndrome, as I earlier said, it basically is because of insulin resistance and obesity. So the cardiac manifestations that we mainly come across are, first of all, the hypertension, any atherosclerotic vascular disease or risk factors related to that. Angina is what we come across in our OPD. A lot of patients just come asymptomatic, and as a part of a protocol when we do screening tests with stress test to echo, a lot of patients we are seeing these days come positive with a positive stress test and completely asymptomatic. So these are the patients we need to refer to cardiologists and for the further management. And now, as you rightly said, sir, they all form a part of metabolic syndrome, or now as we call it, the CKM syndrome, the cardiorenal metabolic syndrome.
Dr. Tanmay, as a physician, I am able to pick up a frank MI, and I can also pick up a frank stroke. It's not too difficult to diagnose that. But what about the subclinical ASCVD that you see, and the atypical angina, atypical ASCVD that you see, the ones that we miss? Could you share a few symptoms, a few clinical presentations that you've encountered where perhaps if we had been more diligent, we could have picked them up earlier and, prevented them from getting into irreversible myocardial damage or maybe cerebrovascular damage?
Sir, in Indian scenario, if you see metabolic syndrome or any other patients, they have more than one multiple risk factors associated. Say, for example, undetected diabetes, undetected hypertension, or dyslipidemia. All these risk factors doesn't add on the risk. It in fact multiplies the risk, exponentially multiplies the risk. Say, for example, if a patient has 3 risk factors, they don't add on the cardiovascular risk. In fact, they have exponentially increased to 8 times the risk, 2 to the power 3. So this thing is very commonly seen in our Indian patients because we don't have preventive health checkups done very commonly in India. Second important thing, what we see is delaying of presentation to hospital. Even if we have some symptoms, there is commonly seen that there is a delayed presentation to the hospital. Or those patients who have atypical symptoms, like not typical angina or chest pain, severe chest pain, many of them, they have, gastritis kind of symptoms where they have burning sensation. But most of the, and none of the cardiac patients usually present with a typical book picture kind of angina. They have wild variation of presentation. Some of them, they have effort angina, shortness of breath, especially seen with diabetes patient or elderly patients, or especially females have atypical presentations of MI. So what we usually tell is, we all should promote or inform all our patients that we all should get your regular health check done irrespective of your symptoms. Like at least we should do a 2D quant treadmill test once in a year to make sure that you don't have any underlying blockages, which can be preventively or early detected and then treated on right time before an MI comes. Second important thing, as I told you, like silent killers, we call it as hypertension, diabetes, or dyslipidemia. They don't have any symptoms in their initial phase. Such patients, if we do a routine blood investigations or evaluation and detect them preventively, we can treat them on time and then prevent the target organ damages or end organ damages for those patients. So preventive health checkup, I say, or if any atypical symptoms, at least all our patients should go and make sure, or at least do an ECG, go and make sure that it's not a cardiac symptom and it's just an atypical presentation.
Even I feel that in the OPD, we have read Harrison's textbook of medicine, but that doesn't mean that the patient has read Harrison's textbook, so they may not present the same symptoms that Harrison writes. And always these symptoms are different. And thanks for pointing this out. We need to be more vigilant and we need to be more proactive because the disease is increasing so fast. Dr. Ajit, from Kolhapur belt, there is a Marathi proverb which says that 1 plus 1 is not equal to 2, 1 plus 1 is equal to 11. And that's what Dr. Tanmay alluded to. When you have all these diseases together, then it's not an arithmetic addition. It's actually a logarithmic exponential increase in risk. So what happens when the kidney gets involved? What does metabolic syndrome do to the kidney? What does the kidney do to metabolic syndrome?
So, as you pointed out initially, that it was because it involves diabetes, dyslipidemia, hypertension, and each of these diseases individually as well have impact on the kidney function, and more so when they are not properly controlled or not early, if there is no early diagnosis. So each of these diseases, like with insulin resistance, there will be more and more hyperglycemia, which results in increased risk of kidney damage because of glycated end products injuring the kidneys. Then with hypertension, there will be increased intraglomerular pressure, which eventually will cause damage to the glomerular filtration or glomerular basement membrane. And in combination, the risk becomes even more prominent in the kidney patients, especially if patients develop microalbuminuria. It will eventually progress to macroalbuminuria and will damage the kidneys more and more, especially if they are not diagnosed early or not managed properly.
And Dr. Sajal, now we have this interplay. Our topic for today is metabolic syndrome. We are looking at the interplay between hormones, cardiac function, renal function. But now there's a new player, and everybody seems to be talking about adiposity or obesity. So this adipose tissue, is it just a structural challenge that we face as human beings? Is the adipose tissue an endocrine organ? Is it a source of hormones? Is it a target of hormones? What does it do in the body?
Yeah. Yes. So basically, adipose tissue, which was once, known as one of just the organ, has a very, very important role, especially in this whole scenario of metabolic syndrome, obesity, etc. So adipose tissue is itself does produce certain factors especially inflammatory factors like interleukin-6, tumor necrosis factor alpha. All these inflammatory factors are produced by adipocytes. At the same time, it is also a source of hormones like adiponectin, resistin, etc. So all these hormones lower levels of adiponectin, increased resistin, interleukin-6, TNF-alpha, all of them play a very important role, especially in insulin resistance. And again, insulin resistance, as we were talking about it earlier, the pathophysiology behind all of this is insulin resistance, further leading to complications like PCOS in females, leading to hyperandrogenism, etc. In males, it can lead to obesity-related hypogonadism. So it's just not just a tissue anymore. It is a source of a lot of hormones. It is also a very important target for anti-obesity treatment. It is also a cause for a lot of other conditions other than just obesity.
Thanks, Dr. Sajal. Just to summarize, the adipose tissue is a source of hormones. The hormones you can classify as being harmful, helpful, and houseful. The harmful
Yes.
hormones, like Madam said, interleukin 6, TNF alpha. The helpful ones, like adiponectin. So in obesity, you will end up having more of harmful hormones, less of helpful hormones. We
Right.
also have a third type of hormones, which are called the houseful hormones, like leptin. But if you have leptin
Right.
resistance, then the houseful hormones won't work. You won't get to know that you are satiated. You won't get to know that you're eaten enough. The adipose tissue is also a target of hormones. And these target hormones you can classify as building hormones and breaking hormones. The building hormones are the anabolic ones, like insulin, and the breaking ones are all the counter-regulatory ones, like adrenaline, noradrenaline. These are the ones which take the body.
Right.
Yeah. So we have all these hormones now coming out of the adipose tissue and attacking the adipose tissue. But adipose tissue, Dr. Sajal, we already know it's not only there in the tummy or in the visceral fat, it's there all over. So Dr. Tanmay, as a cardiologist, you must have been doing echos for the past decade. How frequently do you see fatty heart? Is there a term like that? Fatty epicardium, fatty pericardium, fatty myocardium, and how frequently do you see it? Do you remember the first time you saw fat around the pericardium or epicardium?
Yes, sir. I mean, like we see few of the patients there is having fat around the myocardium or pericardium, as to be very specific. But very few of the patients we see those this thing on echo. Most of the times, what we see, especially in metabolic syndrome, is the concentric LVH part of it. For those who have not been treated, hypertension or their hypertension have not been diagnosed. So concentric LVH is one part of which where we see. Or if there is a myocardial dysfunction, microvascular dysfunction, we see diastolic dysfunctions very commonly for those patients, irrespective of being hypertensive or non-hypertensive. So there are some indirect markers where we try to figure it and find out. LV filling pressures are seen. Most of the patients will be very high, especially those not being adequately treated for hypertension or those having target organ damages. Endothelial dysfunction is seen on angiographies when we see there is slow flow in the coronaries for those patients. So these are some indirect markers where we see for those patients, who. So metabolic syndrome is not just about the blockages in the artery or atherosclerotic disease, but it includes all this cluster of diseases, which includes endothelial dysfunction with slow myocardium or microvascular dysfunction, concentric LVH, diastolic dysfunction. These all parts also plays very important roles.
And let us all spare a thought for the cardiologist who works non-stop throughout the day, throughout the night. We always speak of person-centered care, person-centered approach attitude. But Dr. Tanmay, when you have an obese person, a person living with morbid obesity in front of you, in the OPD, in the cath lab, what are the challenges that you face? We never bothered about that. How easy, how difficult is it to intubate if required? How easy, how difficult is it to get a femoral access? Any challenges that you face?
Yes, sir. I mean, like those patients definitely due to significant subacute fat and all those things. In intubation, they usually have a short neck, so intubation is difficult for them. For getting radial access is still better, but femoral angios and plasties O2, for them it is really difficult to enter because most of the times we see whatever the maximum size femoral needle is available, even that doesn't reach to the femoral artery. This is very commonly seen. And we see if metabolic syndrome or obesity per se is not very seriously taken in our Indian patients. They think it is just there. They don't take it on unless they have any significant or major disease, though they don't take it very serious.
That's unfortunate.
And they don't understand our challenges while treating them also.
Well, Dr. Tanmay, we understand. So see, and now everybody who is listening to 4D, that's detailed discussion and dialogue, we also all understand. So the next time we counsel a patient, whenever we are sending to a cardiologist or a nephrologist, we'll tell them, see, these are the challenges, be patient with your doctor, and there may be extra investigations required. The hospital stay may be extra. So it's not that you will walk in, get a radial access catheterization, TC and then walk out after 4 hours. That's not going to happen if you are living with obesity. You might have to spend a few extra hours in the ICU. Dr. Ranjit, Dr. Tanmay just mentioned that we don't take obesity seriously. What about the nephrology fraternity? Is there something known as fatty kidney? Does obesity impact the glomerulus? Otherwise, Dr. Sajal, now we have spoken about the problem statements. Yeah, Dr. Ranjit, you're with us. Dr. Sajal, we've spoken about the problem statement, and
Yes.
suddenly we realize there's a lot of metabolic syndrome in our OPD. We talk of
Yes.
the heart, the kidney, the endocrine organs, but so many other things, obstructive sleep apnea, the fatty liver.
Right.
For our terms like fatty kidney, fatty heart. Dr. Ranjit, would you like to comment upon the fatty kidney? Maybe the scientific term would be obesity-associated glomerulopathy. But then that's quite a mouthful. Even I would struggle to pronounce it, and I would certainly struggle to write it, to spell it properly, glomerulopathy. But for patients, it becomes easy if we use these terms. So, Dr. Ranjit, how frequently do you speak about fatty kidney to your patients? Do you encounter obesity-associated glomerulopathy? Spoken of the problem statement now, Dr. Sajal, but what about solutions? We know that we should lose weight. We know we should have a multifactorial comprehensive approach to metabolic syndrome. Let's focus on this dapagliflozin. Dapagliflozin, what is the class of drugs? How does it act, and what does it do to the endocrine system?
Yes. So dapagliflozin is a SGLT2 inhibitor. So it is a sodium glucose cotransporter inhibitor, which again acts on the kidney or the proximal tubules of kidney, and it has multiple effects. So it has a sugar lowering effect, as we know from the terminology. It is a glucosuric agent, and that is how it causes glycosuria and reduces your blood sugar. But apart from that, it is a co-transporter. So it is a sodium and glucose co-transporter. So along with that, there is some amount of natriuresis, which means loss of some sodium in the urine as well. So this effect of the SGLT2 inhibitor or the dapagliflozin that we are talking about has multiple other effects apart from glycemic benefits. So they are called pleiotropic effects as well. So apart from the lowering the sugar, it also has effects on your weight loss. Not a major amount of weight loss, but you expect a weight loss of around 2 to 3 kgs. It does have effect on your fatty liver, decrease in adiposity. It increases the insulin sensitivity and hence targets the pathophysiology behind your metabolic syndrome or insulin resistance. We were just talking about fatty heart, fatty kidney. So it does have certain effects on your epicardial fat, helps in reduction of your epicardial fat, lowers your uric acid level. So all in all, dapagliflozin as a drug has multiple effects apart beyond glycemic benefits. Also, there are a lot of studies, lot of CVOTs which are conducted, which show that they have reduction in ASCVD, reduction in the MACE, that is cardiovascular outcomes. Also, it helps in the microalbuminuria. So it reduces your urinary albumin creatinine ratio. So it's a kidney protective, a cardioprotective, plus the pleiotropic benefits that I spoke about.
Thanks. Dr. Ranjit, would you like to take this forward? Dr. Sajal said that dapagliflozin acts upon the kidney. So is it a renal drug? How does it impact renal health specifically? And any studies on patients with chronic kidney disease?
Can you hear me now?
Yeah.
Yeah, perfect. Yes.
Hello.
Yes, the kidneys are packed. Sometimes, no, we can hear you now. Yeah, the nephrons are also naughty. Sometimes they play truant.
Yeah. So, dapagliflozin or overall SGLT2 inhibitors have been darling drugs for nephrologists for several years now, and rightly so, because they have shown many benefits in protecting the kidneys, especially in diabetic kidney disease. But if you see the recent guidelines, the dapagliflozin has been recommended even in non-diabetic kidney disease patients as well, because apart from sugar control, they have also shown lot of improvement in terms of proteinuria reduction, and overall cardiovascular health has been shown to be the SGLT2 inhibitors have been shown to be beneficial in those aspects as well. So almost every glomerulonephritis, now dapagliflozin has been one of the first line drug apart from ARBs, and they have shown a lot of promising benefits in many patients.
Dr. Injit, one quick question. Autosomal dominant polycystic kidney disease. Can we use SGLT2 inhibitors there? Why is there a controversy regarding this disease, while there is no controversy regarding the other non-diabetic kidney diseases?
So yes, until now, in terms of autosomal dominant polycystic kidney disease, only recommended therapy involved use of tolvaptan, and it had shown reduction in the rate of progression of enlargement of kidney size in those patients. But now SGLT2 inhibitors have also been shown to reduce the progression of kidney disease or loss of GFR in this ADPKD patients. And yes, I think there are still trials going on, and we are yet to get the final results, but they have shown reduction in growth of cyst size in ADPKD patients as well.
Thanks. And Dr. Tanmay, like Dr. Anjit said, dapagliflozin, the other SGLT2 inhibitors, they help in renal health. What about cardiac health? Do they help in only people with diabetes or in people without diabetes as well?
No, sir. As rightly told, DAPA and SGLT2 both, they are very helpful in both diabetic and non-diabetic patients both. And already Dr. Sejal ma'am has told elaborately about the benefits of DAPA in this thing. But then two important things is, from cardiovascular point of view, if you see, they also help in changing the metabolism of myocardium. So they shift the myocardial shift to ketones, instead of and they increase the efficiency of the heart. This is one important benefit. And the structural changes are also seen, which is, apart from ARNI, no other drug has proven the structural benefit of the drug. So especially in heart failure with preserved and reduced ejection fraction, diabetic, non-diabetic, both patients, DAPA has been seen in showing the structural remodeling also has been reduced, and it has increased the diastolic function also. So in that way, for both the patients, DAPA has shown a significant improvement in both reducing the myocardial mortality, reducing the rehospitalization, because heart failure patient, what we need is reducing the rehospitalization and reducing the mortality rate, and improving the quality of life. So all three benefits are significantly seen with this drug.
And Dr. Tanmay, the modern classification of heart failure based on ejection fraction is preserved ejection fraction, moderately restricted, and reduced ejection fraction. There is one other type of heart failure that we see in endocrinology sometimes, that is heart failure with increased ejection fraction. Maximum will come to the endocrine or to the nephrology clinic. We have severe anemia, Graves' disease, and people with fistula, AV fistula, chronic kidney disease, CKD stage 5 who have got a fistula. Here they will have increased ejection fraction.
Right.
In such patients, of course, we should treat the primary cause, that is Graves and anemia. But would it make sense to give dapagliflozin to such people also, or the focus will be only on maybe reducing heart rate and reducing volume?
No, sir. Basically, what happens for all those patients, of course, as you told, the primary treatment has to be definitely treated. Second thing is, if they are left untreated for longer time, so they lead to tachycardiomyopathies over the period of time. And this structural change in the myocardium over the period of time will lead to at least heart failure with reduced ejection fraction or preserved ejection fraction. So such patients also, if you adequately treat the primary cause, plus if you give this supportive care, they will definitely, we can prevent those patients in leading to those failures.
That is actually very nice, because this has perfect analogy, Dr. Sajal, with obesity. Sometimes we use the term, earlier we used to use metabolically healthy obesity. And then
Yes,
it was
sir.
that, yeah, okay, I am obese, but the rest of my metabolism is okay, so I don't need treatment. But that is a cross-sectional diagnosis. It is a present tense diagnosis. We know
Correct, sir.
that in the future we are going to become unhealthy. So same thing is happening in the heart as well. That in the future you are going to end up with more morbidity and God forbidding mortality. So you might as well act early. Yeah. So, Dr. Sajal, let's continue with this concept of cardiology. Let's take
Yes.
the example of Takotsubo endocrinopathy.
Yes.
Look at the term that I used, Takotsubo endocrinopathy. All of us physicians, we are familiar with Takotsubo cardiomyopathy. It's also known as broken heart. Some of the naughty boys who are listening to us, they might have experienced that when they were in hostel, but then they bounced back. And I see those wonderful smiles from the handsome men on the panel. Yes. So, of course, that is a part. And these Zoom people and StreamYard people, they will censor it also if we go further in discussion. But let's go back to our history. The first documented case of Takotsubo cardiomyopathy did not come from Japan. It came from India. And that is King Dashrath, who was father of Lord Ram. So when you read the Ramayana and you read the process, what happened to Dashrath, how he behaved, what happened when he was told that his son has to go into exile, that is a classic example of maybe unstable angina, finally resulting in his death, or maybe a broken heart syndrome, Takotsubo cardiomyopathy. Let's go through this one by one. Dr. Sajal, what would have happened to King Dashrath's hormones when he was given this, news of grief? He's going to be separated from his son. What would have happened to his hormones?
So first, I think Takotsubo, or the analogy that you said, I think the first thing that happens is an excessive rise in your adrenaline, noradrenaline hormones. Also, there is an increase in your cortisol, and that is how it leads to myocardial and endothelial both dysfunction, leading to cardiomyopathy. Is what would have.
And Dr. Tanmay, the heart is also an endocrine organ. We thank our colleagues in cardiology and medicine for taking care of it for us. You see, because in endocrinology, we are so busy doing other more important things. So things like PTCA, things like angioplasty, of course, it's an endocrine organ. I mean, everybody knows the heart is an endocrine organ. So, but what would have happened to King Dashrath's cardiac hormones? What would have happened at that time? And supposing he was alive today, what kind of hormones would we have used to investigate? Point of care testing, what would we have done?
Right, sir. So, as ma'am has already told, all these stress release hormones, sudden stress to the heart, all these hormonal changes suddenly will especially show to those patients who already have some underlying risk factors. Those patients are likely prone to have, all this sudden Takotsubo or, stress cardiomyopathy. We call it a stress cardiomyopathy also. So, any kind of stress, physical stress, mental stress, all these things leads to sudden surge of hormonal changes, and then our heart gives up. So that kind of myopathy is, so we call it the stress cardiomyopathy also. And the same thing happens in gym also. When there is sudden extreme activities without any training for the heart. So all this stress also, if it is your heart is trained to take this, then it is always ready to take it. But if sudden any kind of stress to the heart, it will give its way. So same thing might have happened. His heart was not trained to take this kind of stress, and then sudden stress, maybe it's physical or mental stress, he might have had that incident. But this is commonly seen with those patients who have underlying risk factors, maybe smoking or metabolic syndrome, diabetes, hypertension, dyslipidemia, and all those.
So there are at least two risk factors for Dashrath that I can think of. First of all, he was elderly. Secondly, he had infertility in the past. See, he had 3 wives. All 3 would not have had a female factor. It would have probably been a male factor infertility, which means he would have had some sort of endothelial dysfunction. Certainly, there was a hormonal issue. But what about the natriuretic peptides? What do you think would have surged in him at that time, and how would we investigate today if he were to come to, let us say, seeking medical care from you?
So now we have 2 important tests that we can see for the myocardial strain. Say for example,
Carry on. Yeah. Dr. Ranjit, would you like to continue further? Anti-pro-BNP.
Hello.
Yeah. Okay. Tanmay is back. Yes. Right.
Yeah. Sorry. So there are 2 important things. Anti-pro-BNP also gives us a fair idea where there is sudden surge of release of this thing, BNP levels. So these are 2 important tests that can help us in knowing that how much strain or stress the heart had.
So troponin T and NT-proBNP, right?
Yes.
Dr. Ranjeev, now nephrology is a very tough nut to crack. The numbers that we get for NT-proBNP, would we read them the same way in somebody who has normal kidneys? And would we read them the same way, supposing King Dashrath had got chronic kidney disease or maybe acute kidney injury? What other tests would we do? And the description of King Dashrath, when you say, he stopped eating, he stopped drinking, do you think he could have gone into acute kidney injury and then that could have caused his death? We are just blaming the broken heart. Could it have been broken kidneys?
Yeah, it is quite a possibility. Coming to first question, so in CKD cases, pro-BNP is always usually correlates with cardiac function. So we interpret that way. So if any person comes with fluid overload status, we definitely see if there is a raised NT-proBNP, because most of them have common risk factors in both the diseases, as we are discussing. And not so much for the troponin. If it is borderline raised troponin in cases of CKD, we may interpret along with the clinical features, not only the lab value that we have. And coming to King Dashrath, probably his kidney might also have failed, but probably it was a cardiorenal syndrome that led to renal failure.
Okay. Which means that actually everything has to be assessed together.
Of weak heart.
The hormones, his previous endothelial function. So maybe he might have been hypogonad for all that we know. And that also is a cardiovascular risk factor. But Dr. Sajal, let's try to put all this together now. Again, we are seeing that these conditions are so common in our OPD. Sometimes we pick them up, classic MI, classic stroke, classic CKD or AKI, and many times we don't even pick them up. Like till a few minutes ago, we never thought that Dashrath could have had Takotsubo cardiomyopathy or cardiorenal syndrome. Yeah. But let's move on to action now, and let's look at it from a dapagliflozin window. Somebody who is coming to you healthy, no obvious renal or cardiac disease, the person has diabetes. How would you initiate dapagliflozin? And when would you want to initiate dapagliflozin plus sitagliptin combination?
So in those patients who have risk factors, cardiovascular risk factors, ASCVD risk factors, in those patients we would definitely initiate with dapagliflozin. And those patients who have a higher HbA1c. Addition of sitagliptin is basically dapagliflozin mainly takes care of your insulin sensitivity, like we already spoke. It helps with your, it reduces your fasting plasma glucose. So addition and sitagliptin is seen in those patients who, is used in those patients who mainly have postprandial hyperglycemia. So addition of sitagliptin would be in those patients. Also, another set of patients where we would initiate dapagliflozin are obese patients. Though the weight loss is not very significant, 2 to 3 kgs of weight loss is 2 to 4 kgs of weight loss is seen with dapa. Also, in those patients who have MASLD, associated MASLD, these are the candidates for dapagliflozin.
In endocrinology, we worry about hypoglycemia. So you work in Pune city. Suppose a patient comes to you from maybe Eastern India. Her child is working in Pune. Or patient comes to you from Latur district and she says, now ma'am, I cannot come back for the next 6 months. Then what would be preferred, classes of drugs? You are worried about hypoglycemia in that lady and there is no way that you can monitor.
Right. So in such patients, use of metformin, DPP-4 inhibitors and SGLT2 inhibitors like dapagliflozin are we use because these are less likely to cause hypoglycemia as compared to your sulfonylureas. So sulfonylureas, though are very good anti-diabetic agents, they do require monitoring, are more notorious for causing hypoglycemia. And that is why these are the set of medicines, dapagliflozin, sitagliptin, metformin are the ones I would prefer in such a patient whom monitoring is a problem.
So do we have studies, ma'am, to tell this patient confidently based on evidence that, madam, this drug that I am prescribing This will keep your glucose under control. It will not cause hypoglycemia. It will keep your heart and kidneys young and healthy. Do we
Yes.
have
Yes, sir. So, dapagliflozin has multiple studies. So, those lot of CVOTs are available. Cardiorenal safety studies are available, with where through which we can confidently tell the patient that these are cardio and renal protective. So, with dapagliflozin, we had the DECLARE TIMI, where it showed that there was decreased risk of heart failure hospitalization. There was decreased MACE. There were also improved renal outcomes. Next, we also had the DAPA CKD and the DAPA HF trials, which studied the kidney and the heart failure outcomes as well. Apart from this, there are also been studies where dapagliflozin was studied in case of MASLD, certain studies which were done to study the MASLD. So there were certain meta-analysis. Also, recently, there's a short study, or rather a pilot study is being conducted for those patients, use of DAPA in those patients of PCOS, and which is studying the weight, the insulin resistance in those patients with PCOS. So there are definitely studies which back up the science behind using these drugs in patients for glycemic and other benefits as well.
Thanks. Dr. Tanmay, in the cardiology OPD, we can classify all our patients in various ways. One is some people with established ASCVD, others who are at high risk of ASCVD. No third category is going to come. Another way of classifying people with diabetes, people with pre-diabetes, and this makes up 30% of entire India put together. So it might make up 60% of the diabetes of the cardiology clinic. And then there will be people who are euglycemic. So now, established ASCVD, high risk of ASCVD, euglycemic, pre-diabetic, and diabetic. In all these, how would we place dapagliflozin, and how confidently would you counsel your patient that, sir, we are giving you this medicine, it will keep your heart young and healthy, it will prevent you from coming back to me frequently, you will be able to live life without me.
Right. Very important thing to understand, because this is where we land up in our cardiology OPD altogether. So those with established ASCVD, definitely with any evidence of heart failure, or irrespective of that, whether they are diabetic or euglycemic, we initiate with dapagliflozin. Other group, if you told high risk of ASCVD with any other risk factor associated, or any past history of heart failure, may it be any range of heart failure, may it be without ejection fraction, mid-range ejection fraction, or reduced ejection fraction. Irrespective of that, we start those patients with dapagliflozin. So the only question comes is whether the patient doesn't have any target organ damage or any involvement of the organs, and they are at high risk. Those patients, we would think twice, because in those patients, I would prefer mostly the lifestyle modification on priority. And irrespective of that, if they are not able to achieve the target range, then we initiate them with dapagliflozin.
And Dr. Ranjit, in the nephrology OPD also, we can classify our patients in various ways. The easy way that you follow is based on eGFR. Another way is based upon albuminuria. And yet another one is, if you are working in Haryana, then patients will come and ask you as a nephrologist or as a physician, sir, is my left kidney damaged or right kidney damaged? If you're not able to answer that question, it means you don't know your science. So all three questions, based upon albuminuria, eGFR, and left or right kidney, how would we place dapagliflozin?
So again, dapagliflozin has been another mainstay of the treatment for most of the patients in nephrology OPD. Even especially in early stage CKD, it is a go-to drug in diabetic kidney disease as of now. Apart from that, we use it in even glomerulonephritis cases right now. So only concern that we have is currently in the stage 5 CKD patients, diabetic kidney disease patients, where we usually do not prefer it as long as they have a healthy heart. If they have heart failure along with the diabetic kidney disease, then again we go ahead and give dapagliflozin in such patients as well. And albuminuria is one of the main feature of diabetic kidney disease, and in such cases dapagliflozin is the one of the first line therapy that we add to the therapy. So yes, it definitely helps in controlling the proteinuria, and lesser the proteinuria, less is the progression of diabetic kidney disease. So dapagliflozin or SGLT2 inhibitors are one of the mainstay of the treatment in diabetic kidney disease.
Speaking in the same vein, do we need to change the dose of sitagliptin in patients with CKD?
Sitagliptin, yes sir, we usually below GFR 30, we usually do not give much of sitagliptin in those patients. In early stages of CKD, yes, it is definitely used commonly, but not below GFR of 30.
Thanks. So we are here, like we said, this is our first episode of season 3.0 of 4D, but we've got off to a great start. So much of learning, so much of insight, and all of us suddenly realized there is so much we can do in our OPD for patients who come with diabetes or with heart failure or with chronic kidney disease or all of it together. We do need to counsel our patients about everything put together, and we can easily place dapagliflozin and sitagliptin combination in the right time, at the right place. If we do it in a timely manner, we'll be able to prevent a lot of complications. We have questions from across the country for all of you. Dr. Sajal, first question to you, and this comes from Dr. Lakshmi Nagendra in Mysore. She is organizing the ISBMR, Bone and Mineral Research conference later this year. She says, ma'am, earlier there was a concern about dapagliflozin and bone health. Is that still founded?
No. So dapagliflozin, yes, initially there were studies which showed that it does affect the bone health, but those concerns are now they no more exist, and I am not exactly sure of the mechanism, but it is no more a matter of concern, sir.
And Dr. Tanmay, a question coming to you from Bathinda in Punjab, where Professor Bhupender Singh, he's HOD cardiology, he asks, sir, in simple words, can you explain the difference between fluid overload and heart failure? Because many of our colleagues in general practice, we find it difficult to differentiate.
So basically, when we talk about fluid overload, so heart failure is nothing but the fluid overload in the body secondary to heart, or it's a axis. So it's for layman's language, for the patients, it's very difficult to hear it's heart failure, but it's nothing but fluid overload in the body secondary to heart. So this is where we differentiate the patient whether it is heart failure with preserved ejection fraction or reduced ejection fraction, and this echo helps us in differentiating those patients who are in heart failure with preserved ejection fraction or reduced ejection fraction. But otherwise, fluid overload, even if it is secondary to chronic kidney disease and fluid overload in the body, it's still considered as heart failure with preserved ejection fraction, because CKD patients also, they have a LVH, LV filling pressures are also very high for those patients. Even they fall into those categories of heart failure with preserved ejection.
And Dr. Ranjit, in the same vein, fluid overload versus heart failure, this question comes from Dr. Saurabh Sharma. He is Associate Professor Nephrology at New Delhi, Safdarjung. So he says, how frequently in West India do you see patients with the following presentation? They drank a lot of salted kokum juice or a lot of salted buttermilk, and then they come in with fluid overload. Maybe they were traveling abroad and they ate a lot of Thai or Chinese or Japanese cuisine with a lot of salt and Ajinomoto. They come in with the 3 or 4 kg extra body weight, they've gained weight, and after 3 or 4 days, they are back to normal. How frequently do you see this salt sensitivity?
Salt sensitivity has been seen very commonly, sir, because in Indian diet, we see that the food is always we add a lot of salt into our food, and we have even in Maharashtra or Western India, the salt intake has been seen very commonly. Like extra salt intake is very common. Even in parts of Gujarat, the salty food is it is very commonly consumed, and the fluid overload because of increased salt intake has been is one of the common cause in our patient. And many such patients, even if we restrict the extra or excess salt intake in these patients along with fluid restriction, many of them respond very well to the therapy. And even in cases with heart failure also, along with that, even in patients with renal failure also. The fluid restriction and salt restriction helps a lot. As long as we explain them the detailed pathology, that why it is important and how it is important, many patients I have seen in OPD that they follow the diet very appropriately, and they get good results with even the prescribed medicine which were prescribed priorly to them, but just because they were not following the instructions, they were not getting any benefits. So they are happy that even with same medicines, the patient has they get the symptomatic relief.
And this is actually another indication. If otherwise dapagliflozin is indicated in patients like this with fluid overload, maybe somebody has to travel frequently. Somebody says that, yes, I understand the diet that Dr. Ranjit has advised me, but when I travel, I just don't have access to vegetarian food or to the kind of food that I want. So I'm forced to take high salt meals or beverages. So here also dapagliflozin would have a benefit. Dr. Sajal, one endocrine comment. Premenstrual syndrome, weight gain in the luteal phase. How frequently do you see this? And do you think that male healthcare professionals miss out on this history? Do you feel that the nephrologist or cardiologist might end up diagnosing heart failure or, covering a battery of tests when actually it is just premenstrual syndrome? The lady was too shy to give the history, and the treating physician was maybe not sensitive enough to take the history.
Yes, sir. So actually, sir, lots and lots of patients do come to us. So on asking, especially in a female patient, as a female endocrinologist, I do end up asking, is it specifically related to premenstrual syndrome? Has a lot of weight gain. So up to 3 to 4 kgs of weight gain is also seen, and all due to the water retention. So we do come across, sir, a lot of patients who come with premenstrual weight gain, which eventually, with the onset of the menstruation, the weight gain is gone. So yes, there are chances of missing out this history. These are all very temporary or transient, but some females definitely give a very typical history. This happens every month during around the periods. So in fact, sir, we have seen patients who've come complain 15 days of the month they have weight gain. The rest of the 15 days they are fine. So this can be definitely misdiagnosed.
So anything cyclic that you see in the medicine clinic or in the cardiology or the nephrology clinic, do think of the cyclic phases of female hormones. It might be, every month the patient comes, you feel the patient has got atypical angina. It might be endometriosis. Every month the patient comes in with fluid overload or with, you feel, I don't know why the heart failure has been precipitated. It might be just premenstrual syndrome. And in all these, dapagliflozin would be a very safe drug to use actually, along with counseling, along with appropriate management. And it might have a diuretic sparing effect as well. We've had a great discussion. It's nearly 1 hour now, and when you're with friends, you keep on gossiping. The best thing about sport is we are able to make new friends and also meet old ones across the country.
Yes.
But it's time to conclude. So let's have last comments. And Dr. Sajal, your comments. We began with happy hormones. How are your hormones now? How are you feeling?
So in fact, really happy. Lot of things to learn. Lot of things we learn from this. The cardiology aspect, the nephrology aspect. In general, a lot of learning in today's session. One thing I have learned is metabolic syndrome can not be just viewed as, the one we used to see in the past. So I think it is mainly now a cardio-renal metabolic syndrome is more apt word. It includes all the aspects, almost all the aspects of your body, all the hormones of your body, or every aspect is included. So while as an endocrinologist or as a physician, when I'm managing a patient, I think I need to take into consideration every single, the renal aspect, the cardiac aspect, the PCOD aspect, insulin resistance, a lot of things into picture before actually diagnosing and choosing the right medicine.
And Dr. Tanmay, the question coming related to King Dashrath. So of course, you would have done the psychological counseling. Had he come to you for treatment, you would have given maybe psychiatric treatment as well. And whatever invasive procedures were required, you would have done them for diagnosis and if required for treatment. But what about the medical management? How would you have treated medically?
Yes, sir. So definitely, like first important thing is like stress management, because that has precipitated the entire thing. And I think nowadays, I more feel nowadays in the present day scenario, the fast running life, stress management was ignored for a longer period of time. And this stress management is one important thing which every one of us, should explain to our patients, because majority of the patients, they have stress and then, end up in having all these addictions and all those things. So one, I would have definitely counseling for stress management. Then talking about medical management based on this condition, definitely yes. Today we are all talking about dapagliflozin. That is one drug definitely would have been added in the bucket for him, along with all other necessary medications appropriate for his echo and other cardiac conditions as such.
Dr. Ranjit, when you look at the physiology of the body, it's the kidneys which have the final word, excretion. So, final word from your side before we conclude. Anything new that you learned today, Dr. Ranjit? And how happy are your nephrons right now?
Definitely. Since each and every organ, when it fails, the kidneys get stressed out and they start reducing the GFR, and the urea creatinine starts rising. So whenever we see a raised creatinine, raised urea, we always try and find out what is the exact cause for that. And if we see that this particular patient has diabetes, then we always try to find out what are the other organs that are involved in that. So henceforth I'll definitely add like CKM axis component of the diagnosis to that as well, and try and find out whether there is any increased insulin resistance or any heart failure is there or cardiac dysfunction is there, along with the kidney dysfunction that has been troubling the patient. And yes, as in terms of therapy, definitely dapagliflozin will take care of lot many things in the management of cardio-kidney metabolic syndrome. And yes, it is definitely one of the first line drug that we nephrologists have been using, because in nephro we don't get many new drugs more often. So we are very happy to have that something which is there to protect the kidneys against the diabetic kidney disease. And definitely it is one of the mainstay of the therapy for us.
So I think you speak for all of us who are listening. Dr. Tanmay, comments?
Yes, I'm like one more message I would have been given to King Dashrath and to the entire country is like the importance of preventive health checkup. Instead of happy and healthy heart is always better than curing or later treating the disease. So importance of preventive health disease and regular checkups, plus maintaining the routine activities in your day-to-day life to keep your weight checked and all other things. This is one more message I would have given to King Dashrath and the entire country through him.
Thank you so much, and I think you speak on all our behalf, all of us who are gathered from across the country for 4D. And it's been great being with you. Thank you, Dr. Sajal, for your insightful comments. Thank you, Dr. Tanmay, for your very practical messages. And thanks, Dr. Ranjit, for smiling. Finally. It's good that the nephrologist smiles. It means everything is happy in the entire body. And on this very happy note, I'd like to thank all of you. Thanks to our sponsors for giving us this platform to meet each other. And thanks to all of you for being with us, for smiling and laughing together through this academic journey.
Yes.
We look forward to meeting you again next week for the second episode of 4D 3.0. Till then, have a great day. Jai Hind.
Thank you.
Thank you, sir. Thank you so much.